Hey guys, welcome to our channel, ASAPinsight, for quick and easy learning. If you like our content, please like, share, and subscribe to our channel. Today we will talk about first cranial nerve, olfactory nerve. Let us start by looking into the anatomy of olfactory nerve. This is the sagittal section of brain, which points towards corpus callosum. This is the frontal lobe. Just beneath the frontal lobe is the olfactory bulb, which extends to form the olfactory tract. This bony structure is the cribriform plate of ethmoid bone, which lines the olfactory epithelium where olfactory nerves are formed. This is the nasal cavity, through which the odor molecules enter the nose. Let us now move into the details of olfactory epithelium and cells responsible for formation of nerves. The olfactory epithelium consists of cells and glands, which are important in function. This purple-colored structure is the Bowman's capsule. It is responsible for production of mucus and forms the mucous membrane. Another cell is the basal cell, also known as stem cells. These are responsible for replacing receptors monthly. Another important cell is the olfactory receptor cells. These are bipolar neurons, which consist of cilia that collect the odor molecules from the nasal cavity. They also consist of receptors that generate action potential. Therefore, they are also the primary neuron. Apart from these cells, there are other supporting cells, which lies the framework of the olfactory epithelium. These are made up of columnar epithelium. As we move up, we see that the axons of olfactory nerves come together to form the olfactory nerve fiber. This olfactory nerve fiber are 20 in number on each side. Let us now look into the extension of olfactory nerves into the olfactory bulb. This is the olfactory bulb. As discussed, the olfactory neurons in the olfactory epithelium form the olfactory nerves. These nerves generate an action potential, which travel along the cribriform plate of ethmoid bone and enter the olfactory bulb. The dendrites of specialized mitral cells of the bulb, along with the axons of olfactory neurons, synapse together to form the glomerulus. This is a ball-like structure, which receives inputs from the cells in the olfactory bulb. Another cell of the bulb is the tufted cells. These are analogous to mitral cell, but are smaller in size. The periglomerular cells surround the glomeruli and maintain dendrodendritic synapses between mitral and tufted cells. The granular cells are responsible for fine-tuning of the olfactory processing. The neurotransmitters present in the glomeruli generate action potential, which travel along the axons of mitral cells into a tract called olfactory tract, which is also the secondary neuron. How does an odor molecule enter the brain? How is any smell perceived by any human being? This can be understood by olfactory projection pathway. The olfactory projection pathway consists of the olfactory bulb, which extends to form the olfactory tract. Another important structure is the orbitofrontal cortex. This is responsible for conscious perception of smell. For example, you tend to recognize the smell when something tasty is cooked in your kitchen. The olfactory tract extends into the temporal lobe, where it bifurcates into two branches. This area of diversion is called the olfactory trigone. After the bifurcation, the branch onto the medial side is called the medial olfactory stria. This is the third-order neuron. This third-order neuron synapses with the hypothalamus and further extends into the limbic system. This center controls the emotional responses to smell. For example, you cringe when you smell a fart. The branch onto the lateral side is called the lateral olfactory stria. This is the fourth order neuron. This neuron synapses with the olfactory cortex of temporal lobe, the hippocampus, and the amygdala, all responsible for olfactory memory. For example, when you smell a pizza, you remember pizza. Lastly, the reticular formation of midbrain is responsible for the autonomic responses to smell, such as gastric secretions. For example, when you smell your favorite dish, you tend to salivate and generate hunger. Let us now talk about the examination and clinical interpretation. Assessment of olfactory nerve. Starting with history. Note for any change in sense of smell. Ask for any history of trauma. Change in the sense of taste. Duration of impairment. Any medication or treatment undertaken. Also check for any surgical history. After history, check for air movement. To assess the airflow, each nostril has to be assessed separately. Ask the patient to sniff and note for any intranasal obstruction. Look for normal, that is no restriction in airflow. Partial blockage, that is only one nose involved. Or complete blockage, both involved. Moving on to checking the ability of smell. This can be done by using identifiable, non-irritant odorants presented to each nostril separately. Ask the patient to sniff and indicate what they smell. Common odorants used are coffee, lemon, peppermint, perfume. Make sure, when testing one nostril, close the eyes, and also the non-tested nostril. This picture depicts the testing of smell. Each odor is presented at a distance of 30 centimeters. Look for normal, recognizes all smell. Impaired ability to smell. This includes anosmia, hyposmia, dysosmia, hyperosmia, cacosmia, parosmia, phantosmia, or recognize no smell. This could be due to some organic cause. Defining these terms. Anosmia. Complete loss of sense of smell. Hyposmia. Partial loss of sense of smell. Hyperosmia. Increased sense of smell. Dysosmia. Disordered perception of smell. Cacosmia. Hallucination of unpleasant smell. Parosmia. Distortion in the perception of an odorant. Phantosmia. Perception of odor that is not real. Let us now discuss the causes of these impairments at each levels. Lesion at first order neuron. This indicates lesion at the level of olfactory receptor cells. These markings show the location of nasal and paranasal sinuses. There could be an inflammation of these sinuses due to bacterial, viral or fungal infections, and result in nasal obstruction. This is also accompanied by facial pain, fever, and headache. If there are recurrent infections, allergies, asthma, or any chronic inflammation, this can result in the formation of nasal polyps. These are soft, painless growths on the lining of nasal passages. It could be cancerous. If larger in size, they block the air passage and also hinder the sense of smell. Upper respiratory tract injections account for 15–25% of the causes. Another cause for impairment in smell at first order neuron is head trauma. Fracture of cribriform plate of ethmoid bone will tear the olfactory epithelium, hence altering the sense of smell. Another important condition is the leakage of CSF fluid from the nose. This could also occur due to trauma or surgery of head, nose, or ear. This is called rhinorrhea. This accounts for 80% of causes. Allergic inflammations in the nasal cavity and sinuses also cause rhinitis. Let us now see the lesions occurring at second-order neuron. That is the olfactory bulb. The lesion at the olfactory bulb can be categorized into three. The first being intracranial neoplasms. These are abnormal growths or tumors within the cranial cavity. They tend to damage the olfactory bulb or tract. This can be sphenoid ridge meningioma, tumor along the ridge of sphenoid bone, or olfactory groove meningioma, tumor arising from the anterior base of skull. The second category is the developmental syndromes, most common being Kallman syndrome. This is a genetic disorder which causes hypogonadism, anosmia, mirror movements. This alters the development of olfactory epithelium along with defect in neuron, hence affecting the release of gonadotropin hormones from the hypothalamus. Third category is infections. These includes infections such as meningitis, syphilis, abscess, and infections at ethmoid bones are all underlying reasons for defect in sense of smell. Listing out other causes for smell impairment includes aging or presbyosmia. That is due to ossification. If foramina in cribriform plate, there is degeneration of receptive function. Degenerative disorders such as Alzheimer's disease, Parkinson's disease, Huntington's disease. The neurotransmitter dopamine affect the olfactory bulb and Lewy bodies also appear in the bulb. Toxins or drugs. Cigarette smoking, benzene, carbon disulfide, chlorine, formaldehyde, solvents, sulfuric acid, lead, cadmium, nickel, silicon dioxide. Endocrine causes: diabetes mellitus, hypothyroidism, adrenal insufficiency, pseudo-hypoparathyroidism, primary amenorrhea. Metabolic causes: vitamin A, B6, B12 deficiency, zinc or copper deficiency, kidney and liver disease, malnutrition, pernicious anemia, use of medications, chemotherapeutic drugs, antipsychotics, and certain antibiotics. These medications affect the sensitivity of the olfactory apparatus. That's it for this video. We hope you enjoyed watching and got to learn concepts about olfactory nerve. See you in the next video. Thank you.